Good afternoon, everybody. Welcome to Georgetown Zoom. Today we're going to be talking about bioethics in the time of coronavirus. Dr. Ernest Fisher and myself, Sean Welton, will be moderating. Today we have three of our wonderful faculty who will be speaking. Let me first introduce Dr. Kevin Donovan. Dr. Donovan is the director of the Pellegrino Center for Clinical Bioethics at Georgetown University Medical School, and he's a professor in the Department of Pediatrics. He's been a clinician ethicist with over 30 years of experience in the field. He began his training as a visiting scholar with Dr. Pellegrino at the Kennedy Institute of Bioethics at Georgetown in 1989. It was during that time that he began his studies that led to his earning a master's degree in bioethics from the University of Oklahoma. At the request of Dr. Pellegrino, he returned to Georgetown in 2012 as the director of the Pellegrino Center. He earned his undergraduate degree from Notre Dame and his medical doctorate from the University of Oklahoma, as well as his master's in bioethics. Dr. Donovan has published articles in both pediatrics and bioethics and has spoken extensively on both subjects at the local, national, and international level on 4 continents. All of which are dealing with COVID-19. I'd also like to introduce Dr. Daniel Sulmasy, MD, PhD. Dr. Sulmasy is the Andre Helligers Professor of Biomedical Ethics in the Departments of Medicine and Philosophy at Georgetown University, where he is acting director of the Kennedy Institute of Ethics and a faculty member of the Pellegrino Center for Clinical Bioethics. He received his bachelor's and MD degree from Cornell and trained in internal medicine up the road at Johns Hopkins. He holds a PhD in philosophy from Georgetown. He has served on numerous governmental advisory committees, including the Presidential Commission for the Study of Bioethical Issues from 2010 to 2017. His research interests encompass both theoretical and empirical investigations of the ethics of end-of-life decision-making, informed consent for research, and spirituality in medicine. He is the author or editor of 7 books, including the forthcoming Physician-Assisted Suicide and Euthanasia, Before, During, and After the Third Reich. His latest gig is as an online columnist for the Washingtonian magazine with the byline of Ask a Coronavirus Ethicist. And then lastly, I don't have a bio for Dr. Roberts. Dr. Roberts is one of our wonderful pulmonary and critical care physicians who serves as one of our fantastic resources within our hospital for clinical bioethics questions. He constantly gets promoted and is now in the front office, but along with all that, he's also on the front lines helping to coordinate our response to the COVID-19 crisis. So with that, I will let the group start.
Great. Well, I've been deputized to give the initial presentation. We'll get some input later from my colleagues, Dr. Roberts and Dr. Donovan. My title, Bioethics in the Time of Coronavirus, and here's an outline of what I'm going to say. In contrast to a lot of the stuff that you've got floating around in current journals and newspapers, we're going to take a sort of deeper dive and start with ethical principles, virtues, casuistry, so we've actually got a foundation and not make this up on the fly, and then go to issues. And I'll talk about the duty to care, the duty to avoid rationing, some principles of just rationing for ventilator support, and then a tentative rationing protocol that we might suggest for this institution, although it's under development. The most fundamental thing I want to say to all of you today is this, is that the circumstances don't dictate our ethical principles. What we do is we apply our ethical principles to whatever circumstances we encounter. And when the circumstances are extraordinary, as they are now, we need our ethical principles more than we did before. It's not as if, because of coronavirus, everything goes out the window and we start from scratch. We start from an ethical base and an ethical foundation. And it's probably routine and review for many of you, but in ordinary circumstances, the most salient principles of ethics are first, our duty to benefit patients, right? We all went to medical school saying we're going to help patients. That's what we told the people we interviewed with, right? The corollary to this is that we don't harm them, sometimes called non-maleficence. And another corollary that we sometimes don't think about, but we need to more often, even in good times, is that we don't do what doesn't benefit our patients, all right? Because the duty is to benefit them, and there is no duty if there is no benefit. The second typical duty is to respect patients as persons, and the main way we do that is by showing appropriate respect for them as moral agents, what's sometimes called respect for patient autonomy. Patients have something to say, typically, about what the quality of their life is and what may be their appreciation of what benefit we might give to them. That's the way we usually do things, and those are the most salient in typical circumstances. In extraordinary circumstances of overwhelming need and scarce resources, there are two other principles that really are there all the time, but come to the foreground in this particular situation. One is solidarity. That we have respect for the common good, that we're not just doctors and the patients are not just patients in isolation. And it's not just even, as the utilitarians would have it, the sum of our individual good. But I think that if we're good Americans and really understand the common good, if we're good citizens, then we understand the way in which the good of the whole partly determines each individual's good. And an example, for us now, I think all of us feel this, is something like the courage of Jen and Travis is part of the good for us, right? And their being sick is bad for us, even as individuals. That's the sense of solidarity that gets us through a crisis, that the good of the whole is partly even determinative of our own good. And then, secondly, justice, that we want to treat all persons as equal on the basis of nothing but the fact that they are human beings, right? All of our patients, we typically treat that way. We don't even think about it. But in a crisis time, this comes to the fore. And if we're going to do things that need to be stewarding of resources, we want to do so in a fair way if it's going to be just. So that the procedures for distributing the benefits and the burdens have to be reasonable, objective, transparent, and shared by and equally applicable to all persons. All of those principles are going to be at play in our response to the COVID-19 pandemic, and we need to keep them in mind. Virtues are also part of the ethics of being a professional. We became professionals, we became doctors by having professed to care for our patients when we swore our oaths. This means that there are demands that are made of us that are not those that are expected of accountants or shoe salespersons. As one philosopher put it, when I go to the accountant, my taxes are the issue. When I go to the shoe salesperson, the look of my feet is the issue. But when I go to the doctor, I am the issue, right? It's existentially enormously different. And the situation of illness gives the patients no recourse but to trust in us. And we've got to live virtuous lives, particularly virtuous professional lives that make us worthy of the trust that the patients need to have in us. And some of those are the cardinal virtues, like practical wisdom. Never a more important time to think about practical wisdom than now. Every medical act is both technical and moral. We want to make wise decisions about our actions, and we constantly are applying the universal to the particular. Medicine is both a science and an art. The art is treating the individual. In this time especially, fortitude or courage is demanded of us. Physical courage, and I'm putting even ourselves at risk here. Moral courage to do the right thing. And we've got to be careful that courage is a mean, right? It's a mean between being pusillanimous and reckless. We don't want people running in, without masks to start a code, right? We're going to be careful about this if we're really courageous. Temperance. We don't want to overtreat our patients. We don't want to be greedy if we're the only people who've got access to masks and raise up the price. We want to keep a steady hand in the midst of all of this as well. And then finally, justice. We want to treat patients equitably and fairly, and we don't want to waste any resources. And then there are some medicine-specific virtues. Competence. My colleague at the University of Chicago, Mark Siegler, says competence is the first kindness. You've got to be on top of this stuff, on top of your game for this. Altruism, the expectation that we'll put the worth of patients above even our own, that we're willing to take risks on their behalf, obvious in this situation, that we're worthy of the trust that they put in us, that we're compassionate, that we're humble. If any of you watched the news last night, Tony Fauci ended by saying this virus makes us humble, right? And we've got to be people of integrity, honest with ourselves, honest about the data, and willing to do the right thing even when no one is looking. And the fight against COVID-19 is going to demand virtue of us all. And then lastly, casuistry. It's not as if we haven't been here before in history, in the history of medicine. The lessons that we'll learn from this will be medical, political, and moral. But there's a history to this. Sadly, you probably know or have heard that when the Black Plague hit Europe, the first people to leave the towns were the doctors. It's a black mark on us. It's a black mark on us that we need to realize is less than the calling of our noble profession. I'll talk a little bit at the end about yellow fever in Philadelphia, another example. And we've had contemporary issues. These emerging infectious diseases keep coming and will keep coming. HIV, SARS, MERS, Ebola virus. We can be grateful that coronavirus is only killing 1 or 2% of people, not 50%. We don't know what will happen the next time. We've got to learn from this. So with all that said as background, and I think it's really important to set that as a background so that we're not just making this up as we go along. Here's what I think we can say to all of you about ethics in the COVID-19 pandemic. The fundamental message is, above all, to act as normally as you can and act on ethics as your compass. Ethics is what's going to guide you through this. Not that we have to throw out all of our ethics, but we rely on the ethics as our compass. That will mean something about our personal conduct. So, be competent, keep up with your reading, attend webinars, keep learning. The Hippocratic maxim is life is short and the art is long, and you're going to learn a lot in this, and you've got to do so for the sake of patients. Be courageous, but practically wise, that we are in this to care for the sick, but you need to take appropriate precautions for your benefit and the benefit of your colleagues and the benefit of other patients. Be compassionate. You are and will be seeing a lot of suffering and death, more than we're used to, and it's going to call on great compassion from all of us. Be temperate in the midst of this. Osler's famous phrase was equanimitas, right? To keep on an even keel in the midst of this. Try not to lose your temper, right? Be gracious and understanding for others. Or as Osler said, even toward the patients, recognizing the foibles of the patient, foibles not unlike your own. And how do you do all of that? You've got to care for yourselves too, so that you've got the physical, the mental, the moral resources to do this. Make sure you're getting rest, exercise, relying on family and friends or spiritual or religious practices if they help you. But in the event of an overwhelming surge, that's what everybody's worried about. My advice again is to keep treating COVID-19 patients as you would others. The circumstances are extraordinary, but the ethics are not. Practical wisdom says anyone who's sick enough to be admitted with COVID-19 ought to be asked about their plans for advanced care should things get worse, right? We should be doing that for all patients. Here it's particularly important. And when you do so, I think we need to avoid COVID-19 alarmism and exceptionalism. Make sure you're not framing your conversations manipulatively. I think you had a great talk for those of you who were able to participate by Dr. Adams on Monday about how to do this. A few things that I'll add. That it's again about respect for the dignity and agency of the patients as persons. So you say, don't be alarmed, right? We ask everyone who's hospitalized and may be at risk for serious illness about this kind of thing. And most people do fine with COVID-19 and they recover. We hope for the best, but we need to plan for the worst. There are some people, and you may be one of them, who's already decided if they're ever sick enough for any reason they wouldn't want to get CPR or dialysis or put on a ventilator. Are you somebody who's thought about that? Have you spoken with anyone about that? Is there someone we can speak with if you become too sick to be able to speak for yourself? Do you have a living will or durable power of attorney for health care? I wouldn't ask them if they would give their place to someone younger or healthier. Out of the University of Colorado, it drives me crazy because I think that's manipulative. They're handing people advance directives that say that. If the person spontaneously and generously says, if I need a ventilator, it's better for somebody who's younger to take it, then note that as their reason, but don't put them in the position where they feel awkward if they don't say that. And at least for now, say we are not rationing and we're doing everything in our power not to ration. I mean, that's what we're trying to avoid here. So make sure they know that when they come in, and because they're thinking already, they're reading the newspapers, that we're going to keep the ventilators from them. We have an ethical imperative to look at all alternatives short of rationing. Now, do everything reasonable and possible to benefit our patients. That's the basic premise. We try to increase the supply. I think actually MedStar has been doing a really good job of that. We use alternatives as best we can to temporize. If we can keep somebody on CPAP and we have enough CPAP and not enough ventilators, try to do that. Transfer if necessary and possible. I mean, MedStar is a system and we can make use of that. Maybe be creative. Dr. Welton and I have had a little bit of ongoing discussion about this, and there's controversy even among intensivists, but there are people who are even, at least as a temporizing measure, sharing ventilators with tubing into two people who are about the same size. It's going on at Columbia, SUNY Upstate, Ohio State, at least I know of. People got creative in Italy because they don't want to ration if they don't have to. They use scuba masks to sort of make makeshift ventilators. So do everything we can short of denying people who need care and would benefit from care from getting that care. But if we do, if it comes to that, if it's overwhelming and we need to, here's the way you do, I think, ethical rationing. It's the way you really ought to be doing all medicine. It's based upon the patient's need, upon the patient's prognosis, and the prospective benefit for that patient, whether this treatment is going to be effective or not. So ethical rationing is based on those things, need, prognosis, and benefit. I don't think it's based on other characteristics of the patient. Because if we start saying, well, you get this and you don't because of this characteristic of you, we're not respecting the equal individual dignity of patients. We want to decide whether the treatment is worthwhile, not whether the patient is worth treating. And that's a critical difference. So I object to using age alone as a criterion. There should be no absolute age cutoffs that, if you're over 65, sorry, you don't get a ventilator. If we did that, Tony Fauci would die, right? So we don't want to have absolute age cutoffs. No maximizing of life years or qualities, which is another way of smuggling in age, right? Age will figure into your estimate of effectiveness, whether this is going to work for the person. We have good data that if you're over 85 and you're on a ventilator, you're very, very, very unlikely to make it, right? So it will figure into your estimate of effectiveness, but again, it's that the treatment is not worthwhile. It's not that the patient isn't worth treating. Disability alone ought not be a criterion, neither physical nor intellectual. There are people who are saying, well, the first people who don't get ventilators are the retarded or the demented. Obviously, people who are in advanced stages of dementia, there's a decision to be made with the family and the patient. If they're very end stages, they might be very close to death. So it could figure into prognosis or effectiveness, but it's not a priori a reason that you sort of say, nobody who's demented, nobody who's retarded gets a ventilator. And the Spanish intensivists have a criterion of social worth. I mean, that really, I think, is wrong. We don't want to pit the rich against the poor or the educated against the less educated in deciding who gets a ventilator. The need, the prognosis, and the effectiveness. Rationing ought to be based in social solidarity and equal dignity, our concern for the common good, not pitting people against each other, but by equitably applying the rules that will apply to all of us. That's the way we do so that's fair. So for DNR orders or do not attempt resuscitation orders, again, I would say it's basically ethics as usual. Again, I would oppose any carte blanche exclusion of COVID-19 patients solely on that basis. The fact that they've got COVID-19. You can imagine a 45-year-old with COVID-19 and hypoxemia who gets transient ischemia, who might do well and not even need more than a few hours or days of ventilation if they get appropriate CPR and counter shock. Yes, there is a risk to other patients and to staff, and we've got to be careful about that. So if you do this, take proper precautions. Again, be brave but not rash. And again, Dr. Welton has shared with you some protocols for this. The carts have PPE. We're going to limit the number of people in the room. I talked a little bit at the beginning about casuistry. I'm old enough and I've got the gray hair. There were people who were saying in the 1980s that we should automatically have DNR orders for anybody with HIV. We've been there before. I don't want to exclude people solely on the basis of their diagnosis. Nonetheless, now you know as I do, it's business as usual. DNR orders are going to be appropriate for a lot of these patients. Don't be afraid if they're really very sick to recommend a DNR order, and it could be consented to by the patient and the surrogate. And there may be times when CPR becomes effectively physiologically, what I would call biomedically futile, when it either will not work or will be repeatedly necessary with the patient dying anyway, and you can come to that judgment. 3 pressors on the vent already, ARDS, maxed out vent settings, they're not going to make it. You know that, right? So as long as 2 physicians will certify that this is biomedically futile, you can write a unilateral DNR order. Again, the principle is there's no moral obligation to do what can't be done. So I don't want to have all of you doing CPR and people who have effectively no hope of survival. Ventilator withdrawal. Dr. Welton shared with you a Vimeo I watched from Tony Back, who is usually pretty good, but I was very concerned when he says in that this pandemic is changing everything. I want to give you the exact opposite. You've got to stick to your principles. The pandemic is different, the circumstances are different, but the ethics aren't changing. So there should be no unilateral withdrawal of a ventilator from one patient in order to reallocate it to another with a better prognosis. Having started a treatment, right, constitutes a commitment to continue treating that patient unless the patient refuses or it becomes futile. And I wrote about this 25 years ago as sort of a thought experiment, never knowing until SARS and SARS-CoV-2 that it has salience. Starting a treatment on a patient constitutes a prima facie right for that patient to continue unless they either refuse or it becomes futile. And starting the treatment initiates a caring relationship. I think it would be very hard for any of you, it would certainly be hard for me, sort of say I'm taking somebody off the ventilator who's got a 40% chance of survival because somebody's just come by who's got a 60% chance of survival. Even thinking we'd have that much accuracy, I think, is problematic. That being said, it is perfectly acceptable to recommend, as you would in any other circumstance, when the chances of success are very slim and the patient is suffering, the discontinuation of life-sustaining treatments. for a patient with COVID, just as if they had cancer or ALS or any other kind of disease, right? When it looks like the burdens of treatment are outweighing the benefits, have the discussion about withholding and withdrawing life-sustaining treatment. And again, like the DNR orders, there could be a point at which the person is still insisting, but it has gotten to the point of effective physiologic futility. And then I think you can unilaterally withdraw at that point, again by policy, when to a reasonable degree of medical certainty the patient will not be discharged alive, even with full support. And you can come to that conclusion. If two patients certify this, two physicians again certify this, then I think you can do it. Ethics that supports this, again, is that there's no moral obligation to do what can't be done. If the patient is not going to survive, we have no moral obligation to continue treatment. But it's not a sort of 60 versus 40. This is, 99.999% certain that the person's not going to make it. We can come to those judgments. We're good at that. There is always an ethical mandate to care. Again, that's ethics as usual. It's imperative to treat the symptoms and address the psychosocial and or spiritual needs of all of our patients. Maybe important even more in the COVID pandemic. Make palliative care refusals, certainly for anyone whose symptoms are refractory or you're finding difficulty managing them. Anyone who's electing to forego life-sustaining treatment, or certainly anyone who through rationing gets triaged to comfort care or the best available alternative to the ventilator. And think about pastoral care in this setting too. We've got a great pastoral care team. Patients may have spiritual needs even if they're not physically symptomatic, and we should think about those. And if you've got questions, we have an ethics consult service from the Pellegrino Center, 24/7, 7 days a week. You've got our beeper number, and we're there to help. Now, I know people want something more specific if they can. So here, although I can't say that it's 100% the protocol yet, here's a provisional triage protocol that would be based on need, prognosis, and effectiveness. The first, again, is that we do everything possible to avoid triage, avoid rationing, but there could become a triage trigger. The government says we need to do it. There's a shortage everywhere. MedStar as a system says we've got to do it, or it's happened locally already, and Chip Reed says we've got to do it. Then we trigger a triage plan based on need, effectiveness, and prognosis. The question that comes up first is simply the usual one. Does the patient need a ventilator? And that's a clinical decision, and you use the same kind of criteria you would standardly use, I think, to ask for a MICU consult. Does this patient with COVID-19, just like if they had cancer, need a MICU consult? The difference would be if we went to rationing and had a protocol, is that instead of going immediately to the MICU consult, you'd consult the triage team. And that will consist of at least a couple of people, maybe 3, who have ethical expertise and critical care expertise. And this is done for 2 reasons. One is to make sure there's a team, that everyone is kept honest so that the triage decisions are done properly. And secondly, it separates the team treating the patients from those who are excluding the patients. So you on the floor aren't held responsible for it, and the MICU doesn't have to worry, oh, I stopped that patient and I'm doing this one, did I do the right thing? And that the hope is that will reduce the moral distress of the clinicians. The burden goes to someone else, and that might be, for instance, Dr. Donovan, Dr. Roberts, and myself, for instance, might be at one point a triage team. And the next question we would ask would be, what's the patient's prognosis? If we're in a triage situation, patients who to a reasonable degree of medical certitude have a less than 6-month life expectancy, and we think can probably be excluded. They'd be unlikely to survive to hospital discharge, little chance of even short-term benefit. Examples might be metastatic cancer refractory to treatment, end-stage heart failure with hyponatremia, sky-high BNP, and EF less than 20%, end-stage COPD, neuromuscular disease, people who are really at the very, very end stages. We might have to say, get triaged to the best available alternative. The third question then is about effectiveness. Need, prognosis, effectiveness. Will the vent support be effective for this person? And the patients who need a vent and are not terminally ill then come to this. We would probably do scoring. We are sort of recommending Apache 2 over SOFA because we think SOFA is developed for people who are already on a vent and several days into their intensive care, while Apache 2 is more useful at presentation. Apache 2 incorporates age as a risk factor, not as a worthiness factor, and it incorporates comorbid conditions. And let's say we're using Apache 2, if they have a score over 35, mortality is 85% outside of even COVID, they might be said to be a person who would not get a ventilator, and the rest would be prioritized with the lowest score getting the highest priority for a ventilator if we're rationing and we've got to decide who gets on. SOFA, if you're not familiar with it, you do a Glasgow coma score, the cardiovascular things are mean arterial pressure, and of course one of the questions that's in it begs the question that we're asking is whether they're on vasopressors. The question we want to know is whether we should put them on vasopressors. Likewise, one of the questions is mechanical ventilation. One of the things we want to ask is whether they should be put on mechanical ventilation. It's pretty good about prognosis, but it may not be exactly right for this situation. There are calculators for these things online. That's what we would rely on. Here's for Apache 2, as objective as we could possibly be in trying to decide the prognosis for the person with intensive care. Anyone who's triaged off and says we don't need they are not eligible for a ventilator, again, should it come to this, will be kept on the floor. They'll be informed that this has been the decision. They'll be provided the best possible alternative care and offered a palliative care consult. That's the way we're going to have to do it if it comes to it. But I think it's a way that's fair and defensible. Let's hope and pray it doesn't come to rationing. Right? I think Sean Welton may be one too. I'm an Italy looker because I think their picture looks for what we're going to expect. And you can see here, the picture was, before they got serious about social distancing, exponential rise. But I'm heartened by the fact that it looks like their curve is beginning to flatten. I think that's the ethical imperative for all of us, citizens, healthcare professionals, patients, and the government. Do our part to press down firmly and try to flatten the curve if we can. Lastly, just in terms of casuistry and being there before, I'll just bring up the case of Benjamin Rush, for whom Rush Medical School, for instance, is named, a signer of the Declaration of Independence. Right after the Revolution and then the Constitution in the beginning of the Republic in 1793, just a few years after the founding of Georgetown in 1789, a terrible yellow fever epidemic hit Philadelphia. Thousands of people dying. And what did Rush say? Rush didn't say, oh my gosh, we don't have enough leeches, right? Damn that George Washington, he didn't keep the military stockpile of leeches after the Revolutionary War. Everything's a mess, we've got to ration. I've got a great idea. Why don't we do it by quality adjusted life years? After all, we're a young country and we can afford to leave the elderly and the disabled behind. No. That's not what Rush said. Rush said, I have resolved to stick to my principles, my practice, and my patience to the last extremity. That's the attitude that's going to get us through this together if we stick to our principles, our practice, and our patience. So, thank you for that. I've left time for Dr. Donovan or Roberts to add anything more, and then I hope a lot of time for some Q&A. But thank you all for being on the front lines. I've heard nobody from Georgetown who has anything other than Benjamin Rush's attitude towards this, and you're all to be commended for that. Thank you.
Dan, thank you very much. Kevin, why don't you go ahead and I'll wrap it up.
Well, Dan, one thing that has come up in other venues is the question of if we're using some sort of scoring systems, should any points be given to those who are themselves serving in the front lines, the medical professionals and first responders? And I think that we may be close to agreement on this, but maybe not in perfect accord. So what do you think about that?
I think you ought to answer your question. You're an ethicist.
All right. Well, I see this as an issue that would apply a social utility scale to who gets treatment, which then breaks everything that you've been saying, that it should just be on the needs of the patient and not their social utility. However, I do see, you know, the two arguments for it, one which I think is weak, and that is professionals are in the front lines, they need to be rewarded for taking those risks. And I think that argument is weak simply because, as you've already pointed out, we've assumed that risk by placing ourselves in harm's way deliberately as part of our professions. The other argument, I think, could be given some consideration because it goes back to the heart of the concept of triage. As you know, triage is a French term invented by Napoleon's Surgeon General, and it was to sort through those wounded warriors to see which ones could be returned to the front lines if they were given preferential treatment. Now, because we are flattening the curve, then we are deliberately prolonging the pandemic, as it were, because that's the only way to keep it from overcoming our resources. If we are going to have a prolonged pandemic, then it is possible that those who are given some preferential treatment might survive long enough and well enough to be returned to the front lines. That, I think, would probably be the most persuasive argument for giving anyone some preferential treatment. I'm still concerned about it because I don't like the idea of using a social utility argument. It's very hard to keep within boundaries.
Let's hope we don't get there.
Alan, was there anything you wanted to add to the presentation?
How could anybody possibly add to the presentation? So Dan, thank you very much. I want to just say, hey, can you repeat that? But we don't have enough time. So hopefully I can get a transcript of it. I want to just focus on the very first thing that Dan said, which I think is really important, not just for this COVID thing, but beyond. I'm going to invoke a quotation from a movie it was some years ago called A Man for All Seasons. And in that movie, Sir Thomas More says the following: "Some men think the earth is round, others think it flat. If it is flat, will the king's command make it round? And if it is round, will the king's command flatten it?" In other words, there are some things out there that are absolutes and that do not change regardless of circumstance. Now, in recent days, Kevin and Dan and I have had conversations with various people in the hospital, and everybody is shaken by this, unnerved by this pandemic. And there is a tendency, it's a natural tendency, to let the circumstance set the standard. And it's really important what Dan said earlier on, that the circumstances don't set the standard. The standards are there. They are woven into the fabric of the universe. So it is with the principles of medical ethics. Nothing changes these. And not just for this pandemic, but for any other crisis we have in medicine. We have to stick to the ethical principles as outlined. You know, I do think that, you know, with Kevin and Dan's advocacy, we're going to be able to preserve the cura personalis ethos of Georgetown through this thing. And anything that gets handed to us in terms of allocation or triage will be held to the Georgetown standard. This is a fixed entity. And you know, many people are skeptical of the of some of the provisions of the Catholic ethos. Well, we are here at a Catholic hospital, and so it is. And these are good things. They are protective, both of the patient individually, the patients collectively, and of the physicians and nurses who care for them. And that's my 2 cents worth. We don't have anything coming down the pike that we know of just yet that is going to be a new standard of triage, et cetera. What we're doing is preparing both geographically and logistically for a swath of patients that may come through here. And we're also preparing ethically to answer the questions that people will have.
One of those questions that has arisen, I think, falls in line with what Dan was saying. Dan says we are not going to abandon or change our ethical principles. That doesn't mean, however, we can't change some of the technical aspects of what we do in order to balance the good of the patient and the safety of those who are trying to help those patients. A particular example would be in the course of an attempted CPR for a patient. You know, knowing that disconnecting the circuit on the ventilator may aerosolize the room, it may be that we can justify taking measures that would reduce aerosolization without, you know, disadvantaging the patient unduly, but not putting those professionals at risk as well. Is that agreeable to you all?
Well, yes. In fact, those things are being discussed by the critical care team. Is CPR while on the ventilator, allowing for you know, pressure changes in the ventilator. That's an active discussion, but at this moment, it's my understanding, unless this has changed this morning, that they'll stay on the ventilator during CPR. And there will be circumstances in which we will be able to identify that CPR in select patients is going to be physiologically futile and will not be entertained.
Again, I think that's just good medicine, and we should be doing that more often. And maybe part of what COVID does is help us be sharper about our principles and thinking about have we been overusing CPR even within the institution. Maybe questions from the audience at this point, if Dr. Weldon has gotten any that he's shepherding.
So one that came up is it ethical to ask recovered patients directly to consider donations of plasma or blood for both emergency treatment and future research? I.e., is it okay to go into their chart and reach out to them, or should we wait for people to volunteer?
You know, I think this is, again, an extraordinary circumstance, and the ethics of social solidarity, you know, belong to all of us. You know, I think that if one were to, the best person to ask a patient would be the one who had actually treated them. I think It may be a little bit of a HIPAA violation because it wouldn't be for research to have someone else going through the chart. But if you were treating somebody who had done that, I might have the discussion before they're discharged, for instance. Or if you're treating them as an outpatient, sort of say, I want to make you aware of this, this possibility, because I think there are people who want to be able to help, and they may not be aware that they have the possibility of helping. That could be combined with more general announcements to the public that sort of say, hey, if you're a COVID-19 survivor, consider donating your plasma for the possibility of experimental therapy or pure research that could help others. And I think you'd get lots of people volunteering.
I think so far that's been our experience, is that people who have come out on the other end are volunteering and in fact pushing us to do these types of things. Let's see, Dr. Marshall had a different question. Any special advice that we would give patients who are being admitted and who are going to be physically alone in the hospital when their family is not allowed to attend or visit them?
Yeah, that's a very, very good question. I think it's incredibly lonely, to the extent that I think we, I don't know, whether we are giving people their own tablets if they don't have one themselves, to be able to at least be able to talk to people for as long as they can, I think would be valuable. I don't know if we have any that we can donate for those purposes. We're probably using all of them for our own purposes. I mean, many people have them. They could use their own. If they don't, those are the people I'm concerned about. Maybe it would be a good thing to ask the volunteer office about, and people who in the community who want to donate for that person who doesn't have their own tablet, to be able to still be in communication with people. There's always the phone, but I think seeing people's faces at this time is helpful. Not as helpful, sadly, as hugging and kissing, but that human natural tendency to hug and kiss is just the natural tendency we have that the virus exploits, and we just can't use at this time.
Yes, restricting visitors is a necessary precaution in the face of the pandemic, but I think those restrictions have to also be compassionate, which is why our hospital has made exceptions for certain categories, including those patients who appear to be at the end of life, as well as patients and women in L&D. So I think that none of those restrictions should be absolute under these circumstances.
And I think there is some sign that not here yet. We can't change policy right now, but I'm hearing rumors of other hospitals that are softening the stand on visitors. I don't have any specific intel on that, but it's out there.
Another question came up is, what would we do with team members who either refuse or really don't want to become frontline providers?
You know, I think the only thing you can do is call them to the nobility of this profession, and ask them to stand in solidarity with their brothers and sisters in this profession who are on the front lines. You know, none of us want to do this, everyone will have a reason. You know, I think there can be some sensitivity to, where people will be placed, so that, I think if there are, it's probably better to have older physicians, even for the patients independent of COVID, doing taking care of the normal patients rather than the patients in the intensive care unit, just because they probably haven't been in a MICU in a very long time. but that would also protect them. So there could be some sensitivity to those kinds of things. If we get volunteers in from the community who are willing to help and do that, retired physicians, I think, preferentially giving them those safer positions might be something we would do. I don't know that we can actually force people. We can only call them to the nobility of the profession and ask them to do their share for patients, for the sake of their own integrity and the sake of sharing the load with their fellow physicians. I don't know if others have something.
I think that.
I also think we should not forget to inquire as to the reasons rather than presume we know the reason. Reluctance to care. And in some cases, we may be dealing with pregnant nurses and doctors. In other cases, we may be dealing with people who have older relations in their family at home, and they do not want to expose them to that. In other cases, they may be legitimately concerned about a lack of personal protective equipment. These are things that can be adjusted for. These are things that can be supported. And you're right, there's no way we can force someone into the front lines. That's not the person you want to have working alongside of you anyway.
I think at some point, there's a difference between a conscientious recusal of doing something. On the other hand, there's the issue of simply not wanting to participate for the reasons that Kevin enumerated. At some point, we do need to maintain the workforce, and we will, if enough people decided they don't want to show up for work, well, there is recourse that a hospital administration might have to take. The other side of this coin is, let's say we get into a situation where we are in some sort of a triage situation. I can tell you there's pieces of paradigms that may be ethically, morally, religiously objectionable, and in that situation, we do have a policy in place that does protect an individual's right of conscientious objection. And we've recently modified that policy to say that any such conscientious recusal request that gets overridden by supervisors will generate an automatic ethics consultation.
And then myself as program director, I'd just like to speak to the whole group who are here and say I have been so impressed and overwhelmed with the people who are working around me who I think do hold that principle that even in the setting of a pandemic, the ethics remain the same.
Yep.
The virtues that you've talked about, and also just the solidarity where we all feel for each other and we're all there for each other. People just going above and beyond. I would like to thank our speakers for today's talk. That's been very helpful for me and hopefully will be for others.
And the speakers thank particularly the house staff, but all those particularly in critical care, the janitors, the nurses, the EMTs, all the people who are really doing the ethics. It's one thing to talk about it, it's another to be doing it. And I'll echo every word you said, Dr. Welton, the immense pride of the sort of dedication and solidarity of the Georgetown team.
Thank you all.
Thank you.
With that, thank you very much. I know that there will be a large virtual applause. So I will clap on my end. So thank you.
Thank you.
All right. Bye-bye, everybody.
Bye-bye.